before we go ahead, we're basically going to be talking about a new initiative called Arts in Mental Health. It's all about social prescription. We're trying to use each one of you as a member of the focus group. And what I want to do very briefly to make sure that we understand each other and we can talk to each other and at each other in a free way. If you could just 2 or 3 minutes, just tell us a little bit about yourselves, because we have Mike Douglas, who's going to be introducing himself later with the Mississauga Arts Council, and we've got Robin, who is the consultant with Mass Culture. They do a great job, consultants, just talking about the intersection of art and other disciplines in society, whether it be climate, whether it be diversity, whatever it might be. So she's going to record all of this that we're going to be discussing. So I'm going to start on the top right hand. Janet.
Good evening, everybody. My name is Janet Vickers. I'm a family doctor in Mississauga. I've been practicing, for over 30 years. I also used to work in the emergency department. And fast forward, in addition to my practice, I also do the medical care for the inpatient psychiatry patients at Credit Valley Hospital. So I have I guess a soft spot in my heart for mental health and the impact that it has on people, and look forward to learning anything new that will be available to help my patients. So thank you.
Janet. Thanks. Sunny.
Well, hi, good evening, everybody. Nice to see you all. And my name is Sunny Johnson. I am a psychiatrist in the community now. I used to work at the Credit Valley Hospital, which I retired from there now about 1.5 years ago. So I'm doing a private practice now in my office. Lately, I'm calling patients from home. And I like to draw, sorry about that. I like to draw. And then since then, I was interested in my patients in getting into arts also. So whenever they talk to me about it, then I always encourages them. And there was a time when we had a program, schizophrenia program at the Great Valley. I invited all my patients to bring their artwork, one of the best ones, to post it on the wall. And then so that, most of the people, they bought that, so they were happy about it. So they saw something working out, So I still, even today I had a patient and I talked to her, I asked her, how does that make her feel when she does the artwork? So when the meeting is going on, if I get a time, if I get a chance, then I can talk to you what she explained, what she said when she does the artwork, how does she feel, So right now, I'm a psychiatrist, working in the community, and I'd like to hear from you all.
Thanks, Sunny. Kathryn.
Hi, my name is Kathryn Geertsema. I am the office manager at Mass Culture. So I'm here to observe, to learn from everyone. I'm going to also be assisting Robin and Mike during the conference on the 6th. So I'm hopeful that some of your insights will help us inform that conference. So thank you all so much for being here.
Thank you, Kathryn. Mike.
Hi, thanks for being here. My name is Mike Douglas. I'm the executive director of the Mississauga Arts Council. And a few years ago, we really were inspired by some people that Dr. Saldanha knows to explore the opportunity for creative expression to make a difference for people who have a variety of, let's say, moderate mental obstacles, illnesses. And we did a lot of research and found that there was a lot going on in this field. And we wondered how come it wasn't part of the medical practice in this country to really take advantage of all this great information, research, and experiences that would help people feel better, work better, get back to work, get out of the house, live a full life. I mean, tremendous benefits attached. So it became our little mission to try and get arts into medical practice.
Thanks, Mike. Karissa.
Hi, everybody. My name is Carissa Gregorio. I am an occupational therapist for the past 17 years, but currently my role is professional practice lead for occupational therapy, recreation therapy, and music therapy at Trillium Health Partners across all sites. So my background, I am an occupational therapist. I still practice. I worked at Credit Valley Hospital. My first job was actually on 2D mental health. For a few months, and then I went away for a bit, came back, and for about 12 years I worked with in the mental health program in child and adolescents with Dr. Peltz in the developmental program, and I worked with little kids with developmental disabilities, and with my practice lead role for the past several years, I've now shifted back to adults for rehab and inpatient. So I kind of do a lot of different things, and I also have a private practice for pediatrics on the side as well. But I'm very fortunate that Dr. Saldanha found a way to get to my email yesterday afternoon. This is very much an interest of mine, and with my occupational therapy background, being practice lead for also rec therapy and music therapy, we see definitely the value of arts and mental health, and being part of child adolescence too. I remember back in the day, we used to have a running group as well with the social worker, and I know that really gave a lot of engagement and a boost of positivity for individuals. But for OTs, we definitely use meaningful activities to get people back into a group, self-esteem, things like that. So I'm hoping I can provide some insight and help to the group here. So thank you for finding me, Dr. Saldanha. It's very exciting.
It was an interesting conversation. Busy as all of us are on my way to work, I call up the physiotherapy. I said, I want to speak to your supervisor. Lo and behold, I get Carissa. She thought it might have been a crisis that I was going to complain about. And when I explained to her, she was on board. So we as physicians, we can do the social prescription, but I think the actual work will probably be where occupational therapists will understand the importance and be able to implement some initiatives. So I think having an occupational therapist is right. Next, I'm going to invite Saba to speak. Saba is part of my four, and when I invited her, she said to me, I don't know whether I have much to contribute kind of stuff to it. But let me tell you, Saba, as a family physician, Janet, you and I, we see so much of this in our practice of mental health, and we just want to get the sense from you as to tell us about yourself, and then we'll get into some observations.
Sure. Hey, everybody. I'm just so honored really to be a part of this group tonight. So yes, I'm a family doctor. I've been practicing since about 2005. I am an artist wannabe, but my kids and my husband, actually, whatever they make is great. And it's funny because during the pandemic, we would sometimes have my husband would start drawing, and then the kids would draw, and then I would draw, and it just changed the mood. And when I saw what the topic was, I was like, yeah, why aren't we doing this? I do feel like I see a lot of mental health cases. I guess family practitioners do. And I think sometimes what happens is if you're compassionate and open to it, the word gets around. So I really feel over the last few years, my patient base in mental health has increased. And actually, with a couple of people, when I want to get them out of a loop and I kind of ask them about hobbies, I was just thinking as you all were talking, I have one lady who crochets. So I was like, can you show me a picture? And she would just light up and start talking about how that would make her feel. And I have another lady, she actually gave me one of her paintings, and I could see the therapeutic effects. So I just think this is such a great idea. And I hope I can contribute to help it grow. I think it's just makes so much sense. I don't want to keep going on and on. So I think that's my my little intro.
Thanks, Saba. And we have Dr. Sudi with us. He is renowned and his reputation precedes him. So over to you, Sudi. Thank you for adjusting your clinic. You and Sunny Johnson both have adjusted your clinic to be here. And so thank you very much. Go ahead, Sudi.
Thank you very much, Colin. And it's very nice to meet all of you. I'm a family doc, been in practice for 52 years. Probably one of the oldest practicing physicians here in Mississauga. Come from an academic background, I was chief at St. Michael's Hospital in family medicine, and then transitioned back to Mississauga, joined my wife, and practicing day-to-day medicine, family medicine, and enjoying it very much. I also run an organization. I'm the president of the Ripple Effect Wellness Organization. And one of the areas of concentration or focus is youth and mental health. And I think there's a big role to play in expanding their methods of getting their ideas and almost therapeutically onto canvas or paper or whatever, or any form of art. And I just want to give you a very quick story of something that happened in the 70s when I first started practicing in downtown Toronto. I had a gentleman, his name was Mr. Brooks. He used to work for a camera store, and he lost his job. He must have been about 70 years old at the time. He came to me distraught because that was the only job he had. He was a bachelor. He had a speech defect. He had a hearing defect. He had bad scoliosis, bad arthritis, and he could, hardly lift up those cameras, and he lost his job. So while speaking with him, I asked him, Mr. Brooks, what do you do in your free time? He said, I paint. I said, okay, so would you bring in some of your paintings? He said, sure. So next day, he brought in about 30 of his paintings. They were fabulous, but they were all kind of dull, lonely, old barns, cloudy with rain and mist, and everything was kind of dark and dreary. However, at that point, there was a United Church minister, also my patient, who was there in the office. And I showed these paintings to him and said, these are absolutely phenomenal. And he said, can I take them with me to United Church headquarters? And he sold the whole lot in 2 hours. After that, Mr. Brooks, I got him to come over to Oakville, hold an exhibition in our church. I introduced him to various people, and he connected with so many people. His artwork began to change. There was color, there was joy. It just changed his entire life. And that was through his artwork. So, but what I'm looking for currently is a way where mental health and other stressful situations in general practice, where art can be therapy. And that is what sparked my interest. And when Colin invited me, I said, I got to get to this meeting. So I'm just very eager and enthusiastic to listen to what is possible. What are the possibilities? So thank you, Colin, for inviting me.
Thank you very much. And now over to Robin.
Thank you so much, Colin. Oh, it warms my heart to hear your stories already. My name is Robin Sokoloski. I have been working in the arts sector for almost 3 decades. I live and breathe the arts. It means absolutely everything to me, which is why I was one of the founding members of Mass Culture about 5 years ago, which is to support the sector for research and policy, and to really make sure that the arts are working beyond itself, to work with people like yourselves and other sectors, and just really learn, what can we learn from each other to really do what I know to believe how transformative and powerful the arts can be in society. So thank you for joining us this evening.
Thank you very much. So I'll try to keep this as tight as possible. Thanks to all of you. I'm going to do some round robin-ly kind of quick questions, and then we will have a discussion. So I'm going to ask each of you to think of two responses or 2 reasons why art in mental health makes a difference? Give it to me in one word. What are the two benefits to the patient? And what do you see as two barriers to its implementation? While you think about that, we are calling this whole initiative a social prescription for art in our practice. It's going to be the merging of artists and healthcare providers. You guys are going to be privileged to be part of this focus group, and as we grow, you will serve as providers of thought and action as we develop a model. So Janet, give me in one word of each, what does art and therapy will it do for your patient?
I think that across any socioeconomic status, some form of art is possible. So there should be few barriers to this person, and it's something that they are doing for themselves. So they are participating in their own treatment program rather than having to take medication. It's something that will be of therapeutic benefit for them, by them.
So you'll see it's a non-pharmacological intervention, some sense of ownership.
Yes.
Perfect. Sunny, what do you see as benefits to the patient to engage in such an initiative?
So, like I said, I was talking to one of my patients, and I've been talking almost every week, because I got so many patients who are doing that, I encouraged them. So today, because of the meeting, I asked her, what is that benefiting you? How do you see it? So whatever she said in a brief, at the end, she said, Doc, when I do that, that's the best time of my day. And that's what she said. And then few sentences, if you have got a couple of minutes, I can tell you what she said. I feel relaxed, and when I'm anxious when I started, but when I continue, it relaxes me. It puts me in a good headspace. I don't know what that means. It says, I do wet on wet, but then when I asked her to explain this, she said, the color is absorbed on the paper. Then I had to think about how to fix it, how to do that. Those are I'm letting my brain to work. This is a psychiatric patient, schizophrenic patient I'm talking about, And she said, I can focus on the wholeness. And it is subjective. I look at the positive and negative, the whole image. And I look at the problem, I look at the design, the color, and the shape. And it says, I go into my internal thoughts. So overall, she was saying, that's the best time of the day. And she feels so relaxed. And I think that's doing more than my pharmacotherapy, which I am giving her.
Excellent. So what I heard from Janet was self-esteem, and what I'm hearing from you is a sense of self-being, self-worth.
Satisfaction, yeah.
Saba, any thoughts about how your patients you think do or will feel when they are engaged in this non-traditional way of managing mental health?
Yeah, so I've been jotting some words that were coming to my mind. So I think therapeutic, uplifting, empowerment is what I think of, because if they're, let's say, even like a simple little project to get them started and, they do it, right? Control, getting to pick colors or whatever they want to do. Hopeful, give pleasure. And I said tactile because it's something they're touching and seeing. And so those are things that, I would hope they'd get out of it. Hindrances I can see is maybe self-doubt, like if they didn't think of art as a part of a treatment, being like, I'm having so much trouble at my job and you want me to draw, kind of thing. So kind of some pessimism. We know that sometimes they're looking at things through a negative lens. So we would have to sort of coach them through that. Did I say self-doubt already? So those are just, I had more positives, but I just, when you were saying some hindrances, that's what came to my mind just through the lens of patients and thinking.
Just picking up on that, I remember being part of a program where abused women who were just totally neglected, emotionally, physically neglected, were asked to be part of this program, and they displayed all their artwork at the Mississauga Arts Library, and they came up to speak to their art. The sense of breath of fresh air that they had. They felt accomplished, that somebody was there listening to them. They had an audience. It was so therapeutic, to pick up on Janet's point. Sudi, what comes to mind with your patients if you were to inject art? What would you see as their outcome, their reaction, and what do you see as some of the potential concerns they might have in that process?
Well, I think there are two things. One is the expression of thought on canvas displays the internalized emotions sometimes. So apart from therapy, can be diagnostic, as Sunny was telling us. Many poets have illustrated their poetry, like Khalil Gibran in his Prophet, his illustrated poetry. We might be having a different visual. He has a different visual. People like even Rabindranath Tagore has expressed his ideas and thoughts in art. So I think it forms a bridge between the conscious, the subconscious, and almost like a diagnostic tool for physicians in the expression of art. The second thing is, for me, the importance, as somebody else said, was that there's pride in what you do. People are paying attention. They're not doing it. Doing it in isolation is a little bit more difficult. With the pandemic, I think the ability to communicate with other people, like-minded, doing something together, is almost like group therapy, art therapy. So I know a couple of youth that are kind of isolated right now, are having major issues. And if they were brought to an art class and they were able to interact with others, and I think that would be the second benefit, really.
What do you see as potential impediments from the patient's point of view and from your point of view in terms, okay, let's talk about the patients. We'll come to what the impediments are for us as physicians, but from the patients, I think you mentioned the isolation piece. Is that doing artwork in isolation? You see that as a potential impediment?
Yes.
Okay, so now let's get somebody who really sees this therapy in action in a multifaceted way, and that is Karissa. Karissa,
Yeah.
as an occupational therapist, you're looking for these intersections of medicine, non-medical aspects, and looking at outcomes. Could you shed some light on what it does to the individual?
Yeah, so when you asked the question, my first thought was, when we engage with an individual on assessment, is an engagement therapies, what is meaningful to them and what is purposeful to them, right? And so in art, as an OT, we look at occupations, which is basically anything that's meaningful to somebody. So instead of, oh, let's, color a random thing, what do you like to do? Like what is something that you're interested in? Because being in a hospital, everyone's busy, you can be in your room. So how can we engage you that you are doing something that's stimulating for cognition, physical? So usually it's art, and as therapeutic recreationists too, they do tend to do a lot of more of that music, art, and a lot of that productivity stuff like crocheting. There's so many cool stuff out there. And when we find that one thing for that individual, and sometimes it could be gardening, we try to figure it out in the hospital, how we can simulate that so they could have that positive feeling and motivated, because, having that as a therapeutic medium, you are targeting so many different levels of many of their potential ailments, right? Not only mental health, but also physical, fine motor, gross motor, social, like what someone had said. Like there's just so many opportunities there to work on many levels of our body and getting better towards the goals. And we're I feel we're valuable in the hospital, because we really do help, I think, get people back into their homes and find resources. So we tend to find resources based on what they're doing in the hospital, so they can continue doing that for helping with recovery. And nowadays too, because of COVID, a lot of patients coming in the acute medicine unit, a lot of people are doing psych consults, Jerry psych consults, because there's so much challenges in isolation and how to re-engage again. And how to do that in a limited fashion when there's so many restrictions and things like that. But what we see is motivation. People want to participate. They want to get out there and see other things and do other things. So we really just try to find what's meaningful for them. And once we do that, you get so much more out of them. And that could even be a simple conversation and wanting to even say hello to their neighbor, very simple.
Thank you. Okay, so let's assume we put something together like that, a program. I think from a medical practitioner's point of view, what do you see as some of the challenges to implementing something? So we've accepted, based on the discussion here, that this is beneficial, it empowers, it's self-esteem, all of the great things that will uplift, decrease in probably use of medication. But so let's say there's a program out there, and we haven't talked about what the program looks like, but let's say there's a program out there. What do you see, or what do we see as physicians, is the physician, medical practitioners, OT and everybody, as the impediment to implementing something like this? Like,
I think access, like that's what I like.
Access is one.
Yeah.
Sunny, what do you see as an impediment of doing it?
I don't think that, the resources, they are unaware of the resources. Like Sudi said, if Sudi was not there, that guy may be still painting in the basement. And somebody has to have a catalyst, somebody has to start that and give them a push to go, because that most of our mental patients they are kind of isolated themselves for different reasons, So when we have the resources available to them, and then when we get a little bit push, they will take off.
So you raised a good point. I've heard access, I've heard availability of resources. So if we as physicians have a catalog of resources, we just tick it off here, go here, do this. We can we can create the suggestion, very much like Clarissa says, and says to somebody, so what excites you about life other than your work and your what excites? And they'll say, oh, I like painting, or I like drawing, or whatever the case may be. Okay, then you go here. So if we have a catalog, we can access it. So you said access, resources.
And also the recognition. Once they get some recognized, when their work is recognized, that's a boost for themselves, Self-esteem will improve, right?
Yes. Janet, what do you see as a potential barrier for us as physicians? You're sitting in your office, you've got this patient who's in mental case, certain element of psychomotor retardation in his personality, and I know you've got 5 other patients waiting in the waiting room. What goes through your mind as an impediment to the social prescription?
Motivating the patient to participate in whatever the eventual program will be, following through with it, giving them, I guess, the self-confidence that they may not think that they're an artist, but to trust in the process that whoever is running the program, perhaps there is a hidden talent there, and to trust me, give it a chance.
So it's convincing them, try to create that conversion of accepting that you do have potential.
Yes. And the other thought, as I've been listening to people, is that, is there a way that part of this program could be those that have talent, whether it's they're comfortable with one-on-one, teaching somebody that doesn't feel they have talent, or, and again, given COVID times, just creating a social connection. So whether it's even over, if they have Zoom or if it is in person, given the right circumstances, I think that it could be another outlet for creating that social interaction.
Good. Saba, you're in your office. What do you see as the barrier from your perspective to initiating a discussion or developing a plan for them? What do you see?
So definitely from the patient's perspective, everything everybody said. For me personally, what I could see being a barrier, at least initially, is I find when somebody comes in with mental health, they at first kind of want to tell you the story, how they got to that point. You know, you want to empathize, you want to listen. And then that kind of takes a lot of time. And so it's almost, I'm just thinking to sort of introduce it would be for me as a physician to sort of figure out how to get more into action mode, or maybe to sort of stop that at a certain point and just sort of introduce this and then have a follow-up about it. And then I think there would be barriers, like some patients who maybe don't think of art as a part of a treatment, like exercise, everybody's kind of heard it mainstream, right? So they're like, yeah, I know I should, but I don't, you know, but art, they'll be like, you know, I think I could see them sort of being taken a little bit aback and haven't thought about it. And then you want to spend time to sort of not necessarily even convince, but just coach them through it, encourage them, and sort of tell them why you think this is a good option, as opposed to, say, medication or in addition to their other kinds of therapy, right? But for me, I could see it just be like, okay, this talk has gone on 20 minutes. I really want to get this art thing in. And so I'd have to figure out a way of, you know, having a good follow-up and really pushing through on my end, a commitment to take it there, right? That's what I'm thinking.
So that's interesting. When we talk about the time element, like anything else, we won't perhaps have to do, there's so much for us to do. We've got to check and make sure all the lab is okay, the thyroid functions, all of that. So maybe we don't do all of it at the first go.
Yeah.
But perhaps even if we had some literature, a one-sheeter on what is the benefit of non-pharmacological methods of improving the quality of your health.
Yeah.
And I think as Karissa mentioned, the mind is, so when we look at mental health, we just don't look at mental health from above the neck, but we look at its effect on the rest of the body, the lethargy, the weakness, the fatigue, which has general consequences. So coming back to your point, from a time perspective, whether giving them a one-sheeter which talks about it, and then maybe picking it up on a second or third visit in terms of talking to them about it, right? I'm just throwing this out as a possibility.
Even a little video, maybe, you know, just for language. I'm just thinking, I see a lot of people who maybe English not the certain language, but so if there's some kind of like a visual, and even showing people that aren't artists, but just enjoying, or, you know, like through visual thing, like, you know, 1-2 minute thing might be an approach.
But it's interesting you should mention, because I don't think we want to look at art as always and exclusively, and Mike, correct me if I'm wrong here, that it doesn't have to be just the canvas and the brush.
Right.
There are so many other mediums of art within the art field that can be explored. I mean, the younger children want to do computer stuff and I don't know, graphs, and there's so much there that I don't know about. I only know about the brush and the canvas, but there are so many other mediums that we could show them. And when they look at it, then they'll say, wow, I never knew all of this exists, and hopefully pique some measure of interest. Sudi.
I could just add something, Colin,
Yes.
just on this subject with storytelling. You know, you just mentioned, Saba, the need to tell a story, how I got here, what brought this. And it just makes you wonder what would happen if there was a pad of paper and a pen, and they're in the waiting room, and perhaps you can tell us your story of how you got here, because we've seen writing classes for homeless people in particular in Vancouver and more recently in Toronto. It's actually changed some people's lives, where they started to ask themselves what they were doing here and why, and that self-reflection that comes from an attempt to tell your story ends up perhaps changing your story. And there are people teaching memoir writing of different forms in association with the Canadian Mental Health Association here in Peel Region and in Toronto. So that's part of it for us, is we see little bits. You know, this is working over here. Look at what dance does. You know, phenomenal outcomes from dance classes, writing classes, painting classes, video making for young males. I'm convinced if we can get young males into making music videos before they decide to join a gang, we'll have far fewer gangs, because they'll have a different identity. They'll still be cool, but they don't have to get into the drug trade or the high risk activities. So when we see these pockets, that's part of our frustration is, why isn't this part of a holistic creative experiences program that you can call on, as the doctor alluded to? You can go to a website we're suggesting, or print material, whatever, and have a variety of experiences at your disposal, so to speak, where you could, this person has language difficulties, so let's not prescribe writing, but maybe going to a concert would be great for them, or going to a play, or being part of a photography group. And so you've got way more tools in terms of the arts than painting. And that's kind of neat because they use different muscles. Anyway, that's my.
So I'll just pick up on Mike very quickly, and I'll tell you that, of course, it comes out to financial resources. I was privileged to be on the board of trustees of the Royal Ontario Museum at one point, and I had this immigrant family who came to see me. The kid was depressed because of dislocation, trauma associated. And when he was playing with some dinosaurs, he brought the dinosaur, he was 5, 6 years old, had some dinosaurs with him. And it triggered me, and I said, we've got a dinosaur exhibition at the Royal Ontario Museum, but I can't suggest to mom to take the kid to the museum where you had about $15 entrance fee. And so when I was at the board out there, I floated the idea, and we got one of the philanthropists who donated $1 million, and we used that money to give it to United Ways so that they could give free access to coupons to families such as this one that had come to visit me to see those dinosaur exhibitions, and it was a great intersection. Sudi, over to you in terms of what do you see as a physician? Now, you're a physician that's tuned to this. Let's talk about colleagues of ours who don't know much about it, and that will come to a whole different game where how do we educate our colleagues? But what do you see as the impediments in terms of implementing this concept?
I think you hit on a very good point there. Physician engagement depends on the physician's enthusiasm and passion for what they're saying to the patient. If you're not very convinced about it, then it won't come across as something positive. It has to come across as something that you deeply believe in. The second thing is to give them the tools right then and there, if that's possible. I had a guy who was, he was a loner. He used to come in with his clothes and terrible tatters, etc. So I said, hey, why don't you do some painting? You used to do that a long time ago. He said, I don't have the money. So I gave him $150. I gave it from my pocket, and I said, take this and do something with it. The next time he came to see me, he had about 3 paintings that he had done. And we displayed it in our office. I still have one in my office of his painting. So I think we have to get the moment, as Saba said, you have to capture them at that moment. When the right time comes and you introduce the topic, not like a prescription, Colin, but as something that is a gift in terms of healing, not in curing their disease, but healing their illness.
So you're talking about the barrier being that the physician be informed.
The physician has to be enthusiastic. The physician has to capture the right moment. As you said, physicians are busy, doing all kinds of things. Like we all come home and then we have to do 2 hours more putting all the stuff into our EMR.
So hold that thought for a minute, Sudi. I just want to go over to Karissa. I don't want to lose her.
Yeah, we don't want to lose you, Karissa.
Karissa, you've had a chance to hear what my colleagues have said, or our colleagues have said about the benefits and the impediments. Now, if you were given a chance to implement a program like this, from an occupational point of view, what would you see it look like?
Yeah, so obviously from the starting point of physicians first, I think then it would be a referral. Like if there was a program that was built, if say, for example, the mental health OTs, either inpatient or outpatient, or really anybody in the hospital is aware of this as a resource. We have a, we have a Med Psych Alliance at Trillium Health Partners. We have Jerry Psych. We have a seniors mental health outreach program. This could be a program or resource that we can reach out to. And we even have a transitional youth program too, just talking about the youth and everything like that. There's a lot of pockets there where we can refer to the community. But in terms of the OT involvement, and I can just see so many opportunities for, like in mental health OT, when I was in school, it was all about productivity, which in that sense was art in many forms. And storytelling recently has been so powerful. We have so many talented individuals out there, and like what Sudi had said, you have to, being the clinician and trying to find that talent and interest in that person and try to wean it out and motivate them to find that path. So I think that's so therapeutic, and having that skill and education as a clinician to be able to find that. I think it's just developing a program that can be accessible to clinicians, inpatient, outpatient, all over, so that we can utilize it and be able to have our patients continue to use that. And like providing the resources, the money, that's always a challenge for everybody and for us too. So yeah,
I'm gonna ask you quick question, quick response. Would a pilot project work at Trillium? If so, who should we target?
Okay, well, that's a huge question. I think
don't worry about it. Just does it work? Not yes, no.
Yeah, I think it would be, who would we target? I think geriatric population is huge right now, and also there's always tapping into the youth. Okay. I think we'd be doing a lot of data collection, but yeah. So yeah, just before I leave too, part of being part of Trillium, I did talk to my director about participating in this, and she was all about supporting, just as long as it fits. So once everyone has information, please send it to me. I would love to share it with professional practice in Trillium and see how we can help.
Perfect. Okay, that's great. So we will connect. All the best. Yeah. Thanks for making the time at such short notice.
No problem. It was nice to meet you all. It was wonderful.
Okay, over back to you, Sudi. I interrupted you about the barrier piece. Was there anything else that you wanted to talk about?
Yeah, I think Colin, Clarissa touched upon it just lightly, and you alluded to that fabulous thing that you did with the ROM, getting coupons for kids to go and visit, and you got $1 million. We need money. Where is the beef? We need the money to support the programs. Otherwise, the programs are going to die. That's the bottom line, because with all these, that's one of the biggest barriers, Colin. And you've sat on the board of Trillium. You have a lot of influence there. And if they buy into this, are they going to give part of their global budget to?
But like anything else, we've got to create the program, and then we will have to sell it. And I think there's a lot of interest. Sunny, over to you. What if you were to create a program? What should it look like? You're a psychiatrist. You've got me. I'm a person with schizophrenia. I'm sitting there. I don't have a job. I smoke all day. I sleep, I don't know, any time of the day. I have my beer. And if you were going to suggest a program to me, what would that look? And I'm going to be asking Saba and Janet to suggest what a program in your mind would look like.
Program should be, that, it has to have a certain place and certain time available for them, so that they can come either by themselves or as a group, where they can get the information about the resources and how to progress and all those things, or the people who have that, how they can develop into something better, or the people who have some ideas, but they haven't gone into. There are people already, they have something in mind, but they don't know how to start it, where to start it. So
you're sitting there, you've got me across the table from you, and you say to me, Colin, I'd like you to consider art therapy is helping you in terms of your response to this treatment. It's shown. So what would you like to have? What would it? You've given me this advice. Now, before I leave, what would you want to have in place to make that referral? What would it look like? What would you want?
Like I said, they have to have a place that we can refer to.
Okay.
Where they can get the information. I think that we would like to have, I would like to have a piece of information in one sheet of paper, which I don't want to put it in the waiting room, but I would like to have it in my desk so I can give to them and say, because otherwise, there are so many papers over there. This one, I said, this is what I would like you to do and to improve your inner abilities, So that will be a person to person touch to that, So that way we can guide them and then encourage them, and then
so you would have that sheet of paper, and then you would talk to it and try to engage me and connect me.
And then the following appointment, I will check and see how that progressed.
Yes, the follow up. Yeah. Janet, I was thinking we have one link, right? Do you refer through one link? So we have a number of.
We have to.
Yes. So we have a number of boxes out there. Do you think that that is a good source of that network, trying to plug them into something or build on the conversation you and I have had with the patient? I'm just throwing it out. You may have another idea, but I'm just throwing that out.
Probably if we had the referral system ourselves and we're able to bypass one link, if the people involved in one link were aware of the program and can also make use of it if the referring physician wasn't familiar with the program. But I think perhaps the buy-in, if the family doctor is recommending this as somebody that has potentially known the person for years and knows their family, that it would carry more weight, and that we're not sort of deferring it to another level to get it instituted.
Janet, you made a very important point. The power of suggestion by the family physician. Yes, you made that point. If it can be augmented and reinforced by one link, that's a second tier of encouragement. But yes, okay, doctor one-to-one. So let's say you've decided you want to do something for me. I'm this patient here with you with severe depression, major depressive disorder. What would you like? You've made up your mind now that we need to do something. What would it take? What would you want? What tools would you want to have to do that?
I think that, again, part of giving the person, they also have to buy in and participate in it. So if perhaps there was a referral type of form that I could personally write on, please see Colin. I think that he would benefit from this program. I've known him for X amount of years, and over the time, perhaps art, perhaps, or he was a great soccer player, and perhaps,
a tick box, so to say. Perfect.
And then able to give it to that, give it to the patient, clearly, the number or the email to contact.
Saba, I'm in your office, anxiety disorder, social anxiety disorder, and I'm at my wit's end. You're planning to give medication. You've seen me for about 6 weeks now. I've come for a follow-up. What do you see as your needs to introduce me to this whole idea of the program?
Okay, so I have a lot of thoughts swimming, so I'm just trying to my thoughts here. Okay, so definitely we're key. I think, we're lucky that most of us have good relationships with our patients. So I think that trust factor is there. So after I kind of, we've heard everything, and I tell them, like, look, I think there's this kind of therapy, and a lot of times patients are actually worried about side effects of some of the medications anyway. So I could be like, listen, we can try this, and I think this will be good for you. What I would need you know, a lot of them are at capacity. You know, they can't like bounce back. For a lot of my patients, they're like, you know, there was too much to do, I had to read, then they call you, it became a barrier. And same thing with One Link, sometimes they'll give them 3-4 resources, they'll call, they won't get through. So what I need is, if I'm doing some of the work, I have that trust, and I'm taking it to the next step with tick box referrals. So I can take that on, that I can check off, okay, art, gardening, you know, a few things to give, say, Karissa a little, let's say she was on the other side, to sort of, where do we put the person in? I need that to happen, you know? And I think when I do the referral and they do the intake, it not only needs to be an intake, but some kind of a next step. Because what I hear from them is, you know, they ask me all the questions and I don't know when they're calling me back. Like, I don't know what's happening. And this is already, you know, it's a new concept, we're pushing it. So they have to know, okay, like next week, actually, they're going to put me in a class, you know, and just that continuity, not even getting into the resources and how and money and all that, but just my wish list for them would be something tactile, formal, you know, after I do that referral where I've done my part to convince them in that trust and you know, that's what
Perfect. Sudi, do you have anything to add to this? I know you made your comments initially, but do you have anything to add to what it would take to implement something?
I think we need to have a name. We need to know that person who we are referring the person to. Saba mentioned something about gardening. I had a patient, Asperger's, severe depression. He was isolated in his room. I got him to go and work with dogs. The guy changed completely. Then the pandemic hit, they closed down that. And he's back in his den by himself. And I can't even get him a pet. So it's just, I think we have to look at it in, as somebody said, in the broadest possible holistic way, because one pattern doesn't fit all. So I think we need to know our patient.
Absolutely, we need to individualize
who
it.
we are referring to by name and what they can really offer. Otherwise, yes, it's phone calls, barriers to access, go to this website, register here. Minimize the barriers, maximize the access, personalize the connection. That will give it strength to the program.
Listen, this has been great. I am now going to hand it over to Mike and to Robin, because as they develop the program and they have the concepts, that they may have some questions that they may want to throw out over to my colleagues.
I've just been really enjoying what everybody's saying, and I think that obviously the biggest thing is the trust factor, and it's interesting because I'm so focused on the arts itself. So how can we create lines of communication and connection between artists and the health sector? But it's also heavily reliant on the relationships within the health sector itself. So I think that there's a number of different steps. Also creating that really engaging intake process, I think, is really important. I think it will also show some dynamism, something dynamic. If it's not just here's a piece of paper, go get a prescription, but it's actually engaging, interactive, which I think art can do and functions as. And yeah, I think that that those were my observations. I don't really have any questions. I think that we covered quite a bit. Mike, are you back?
I hope so.
Yeah.
I've been hearing all of you, so I don't know what part of me has gone missing. I'm curious how we would convince doctors to take this on with some passion. When I was listening to you, I thought of my own doctor, a very accomplished doctor, but I doubt I spend more than 5 or 6 minutes with them per visit, it seems. And so the efficiency of getting me in and out seems to be pretty important at that office.
But I'm sure you don't have any mental illness.
I don't.
Okay.
So thank you. So is there, that we know of, so is there a different approach then? Because I'm used to physical type engagements, and they're very quick. And I just wonder, when you talked about stories, how do we get doctors involved in believing in or willing to spend the time that you've talked to here? I was quite amazed at how people were talking about listening to stories from their patients. I mean, I don't think my doctor's asked me a personal question in the 25 years I've been seeing him. It's just coincidence he knows my family, because they all go to him too, but he wouldn't ask them anything. So I don't know what to say on that. How do we get doctors engaged?
Mike, you're bringing up a very important issue, and it all depends on how people practice, and patterns of practice differ from, we as an FHO have a little bit more luxury of time. People who work in walk-in clinics or private practice where they have to keep pushing their patients through, they practice very differently. If we need to see a patient, we give them the time they need. And that is perfectly legit in our type of practice. That's the beauty of the family health organization and the FIT and the community care centers. All the others are volume-driven practices. Ours are quality-driven practices. We are rewarded for quality, not for the number of patients we see, but the quality of care we give. And that's the difference, Mike. So we don't need to push through a lot of patients. And we don't want to, and we give them the quality of time they require. So you can't get that all across the board, and you'll get people from, working in very different things. We teach them all this at university, patient-centered, community-oriented practices. And when they go into the real world, everything changes. So kind of a slow point. I think Colin will.
No, but I think you raised. But let me get Sunny into this. Sunny, Mike asked a very valid question. I know I was at the psychiatry round the other day, and Dr. Banoub talked about somebody who enjoyed pets and sent them off, and so the psychiatrists are tuned to it. But how would this kind of an initiative, if you were to start a pilot project, how would this resonate with your colleagues?
Sudi made a good point, because, like it's all time oriented and, volume oriented, but we have the psychiatrists, we have the luxury of the unlimited amount of time. And then, it is more practical. We can do that. We can take the time, and that's what I do. But, I doubt it, in most of the cases in family practice, it's not because of it could be different reasons, but, they had to get the patients out. And I don't know whether they will have the time, to do that. So what I mean is, we're not going to get all the doctors. We'll get some doctors who are enthusiastic about it, and they will find the time. If they don't have the time, they will find the time. So we have to find that type of doctors first.
Interesting. But the other thing, Mike, is that if we were to introduce something like this, if there are inpatients, so people leaving the hospital, they are a quote unquote a captive audience, so to say, where the social worker will engage in a conversation with them in discharge planning, and that can be implemented at that stage. So everybody that leaves the psychiatric department will have had a conversation on this. That's why it was important for me to bring the occupational therapist on board. So the inpatients, we know that they will go out, they will do it. And sometimes what happens is that when patients leave the hospital, they go and see their family doctor. Sometimes the family doctor is informed by the patient of some of those programs that they may not be even aware of. So we will have to, very much like Sudi say, we're not going to get everybody involved. Once we develop some pilot projects, we will have that focus, that success rate that we can talk about, do medical rounds on it and things of that sort, and get a few cheerleaders and champions. So it's possible. Yes,
certainly.
Sunny was saying something. Yes.
Colin, you raised a good point, because the inpatient setting is a good setup there, because they have discharge planning, and then they can discuss the social workers, the nurses, the doctors. They can all discuss and say, okay, these are the plan, follow-up plan. they can include this is also, you can offer to them. And if the patients like it, they can continue and they can take that information to their family doctor and say, okay, this is a part of the treatment plan. And then that will be an informative session for the doctors also, coming from the patient, right?
So Michael,
I also think
yes,
the
yes,
patients in Emerge, they see an awful lot of patients that, of course, we can't admit them all. But to me, this type of a program gives hope and gives them some purpose. And so I think also educating the people that work in Emerge of its existence and availability.
Saba?
That's a good point about the emergency, because Dr. Johnson, when you were talking about inpatient, I was also thinking that, sometimes I feel for my mental health patients that some that aren't bad enough to be in crisis and get into that Trillium outpatient program, they kind of fall through the cracks, so it would be sort of, that would be one wing. And then we see so many that, they're mild to moderate, right? And so how would we get them tapped in a practical way? I had one other thought I was thinking, maybe I'm jumping a little bit too far ahead, but I had this patient who, he had a lot of mental health issues. He went through one of the programs in Oakville. I forget what the name of it is, but now he's like a mentor for other people. And I'm just thinking that, when this takes off, because I think there's just so much potential here, I could see that some patients would find their niche here and could help act as, taking over the program, and it would help with access and all that too. So, I mean, I know that's the next tier, but I can see it. I can see that. Yeah.
Can I add one more point? Because there is a place called, for mental health patients, there is a place called Recovery West. And that's it's a big location in Steels and Highway 10 or something, There, these type of things are happening. There, if they have the information, they will be glad to help us out. And they will be glad to provide the information to the patients also. This is a drop-in place for the mental health patients,
So we'll have to structure something. So that's great. I'm cognizant of time. Mike, are there any other thoughts, any comments that you want to hear from my colleagues about any aspect of this that
one of the things, I don't have so much a question as a thought to plant. We have this, we use the word pilot, and a beautiful thing about that word is how malleable it is. And so if there was a situation where we could, for example, we just applied to Bell for $150,000 to try and, get started on some programming. Okay. Like, would that cover Peel region? I doubt it. So what would the component parts? So if we went to the doctors who are already interested, how would we find them? If we went to the health clinics that I think were mentioned by Sunny as places to go, and people who've got time, as Sudi mentioned, and people who are captive audiences, as were mentioned elsewhere, these are pockets. And if we could identify the most available or in line with our needs type pockets, whether it's a doctor who really cares about this or a kind of health service that is more amenable or has a greater affinity with this kind of conversation, and feed them information, short videos, paper, a tick box, a website they can rely on, they can just go to. So just for your information, doctors, we've got a website called Arts Care. And we're thinking of this in terms of medical care and arts care. And we have a home for it. So we're thinking, okay, maybe we've got something there because it's so easy to remember. So those are things that I'd love to know if there's a way we could identify those cohorts that are already leaning our way, knit them together into a patchwork of physicians and therapists, and have that be the body of the pilot. Instead of trying to do one universal pilot where we end up with all sorts of conflicting interests, if we can find the friends of the arts and the medical community, we'll get a program and we'll get it financed.
So let me pick up on that while my colleagues think of a response. We look at the medical field, we use the word a multidisciplinary approach to any of our chronic medical conditions. And that includes the social worker, the physiotherapist, the occupational therapist, the physician, and the nurse. So when you're looking at mental health, I think the people that will probably be involved in that process would be the social worker, the occupational therapist, and the physician. One way, like Janet mentioned, is emergency when people with psych issues go in. Another one is, like Sunny mentioned, is about the inpatient for the discharge. Sudi mentioned about a certain number of physicians only that will probably be invited to doing it. Like Saba was mentioning, maybe we need to have a program where you get all the physicians do a presentation at a medical rounds, for instance, and talk about it. But in the beginning, it will be small, but it will, once we have numbers, because doctors want to see just not a feel good, they want to see like outcomes out of these things. And I think a pilot will show that outcome, and we will have to, tonight we won't have the time, but maybe we can reconvene at another time where we can talk what a pilot would look like. Do we do it for geriatric psychiatry? Do we do it for child psychiatry? Do we do it for young adults? We're very much like Sudi mentioned about avoiding these people going to gangs, young people between the ages of high school, between 16 and 25, like we'll focus on that. So, because those are the most vulnerable people that get into trouble. They call them youth at risk. So we'll have to work through with this, but I think there are opportunities. I'll open the floor now to others. I think I've spoken too much.
I think in follow up to that, Colin, for a pilot, coming up with, you know, probably one group that we, in our opinion, feel that the need is great and the potential for success is also there, and putting our efforts into that one particular group, learning from that experience, and then going forward from there.
You raise a good point, finding out a group where there's opportunity for success. Yeah, okay. What would a pilot look like, Sudi and Sunny? Any idea who should be part of the pilot?
Well, there has to be a high level of interest and willingness to engage and recognize the patients who, if you're going to start this, put the process in, the strategic steps. What is the end point look like? So again, you need to gather up your cohort of patients. Are we going to go to by division? Are we going to have a totally flexible span of youth, middle age, and elderly, or is it going to be only for seniors? Are we going to chunk it down to little pieces, doable parts? So I think for a pilot project, one has to think of what is the question that we have and what is the outcome we are looking for. Just like a research project, once we have that, what is it we are trying to accomplish and what is the outcome we're looking for? And then after that, you submit your application for money. So if it is a successful project and has to expand, show me the beef, get me the money, right? So Colin, I think those are the 4 steps.
And you know, it was interesting you should mention, because one of the things I was talking to Mike is that when you have somebody join a program, they fill out something the equivalent of a PHQ-9. For the non-medical people, it's a form where we do some measurements on people's emotional feelings and criteria with respect to assess anxiety. So depression. So we do something the equivalent of PHQ-9 on entry of the program, and when they exit the program. So those are tangible numbers. But developing a program is good. Did somebody else have a comment? No. Okay. Any final comments, Robin, Mike, before we call this a night?
Wow, what a fabulous conversation this was. I feel so lucky to be on the screen with you guys. wonderful. This is so encouraging, and it is just infused us with enthusiasm that we're on the right track, that you're with us, and we just have to find a way of communicating it effectively to groups. We are in touch with the Minister of Mental Health. We are pushing him now, and we will continue to do so. This is the beginning, and you're not alone. We're not alone. So I think we should just make sure we get together again, because perhaps you do this every evening. But for me, it's the most intelligent, interesting evening I've had in a long time. So I'm very grateful. Thank you.
Mike, we should introduce this course into the university medical curriculum at some stage. To me, that would be a big win if we can get it at UTM Medical School.
So Sudi,
say, hey, come on.
Sudi,
integrate this into psychiatry or family medicine or whatever, right?
You're talking about the promise.
The promised land.
In mental health.
We need the manna for the promised land.
Yeah, it's in prime. But Mike and Robin and Kathryn, I just want to tell you that my colleagues, with just one email, responded to it swiftly. And one of them, like Janet and Saba, said, I don't know. I don't know how to contribute. What am I going to contribute? And I said, I know what you're capable of. And they delivered. Sudi is a leader in his own right, starting a huge organization, brings in money, lots of money.
No, I wish it was lots.
You do a great job. You contribute so much to the hospital. I'll tell you about Sonny Johnson, a very busy psychiatrist. I spoke to him last Thursday. He has his psychiatric rounds every Thursday evening. Guess what he did? He told his colleagues, I have to go on an important Zoom call on a Thursday. I'm rescheduling our meeting for a Friday. Sonny,
thank you.
Sonny, that is true leadership and interest in what you really do for practical. So thank you everybody for making the time. I will drop you, each one of you, a little line. We'll try and put things together. Yes, Saba.
Just a quick thing that came to my brain. I'll be really fast. I like your idea. I think it's really important that in the pilot project, we have measurable numbers. The reason why I'm thinking that is what I noticed with some CME, that's medical education that doctors have to do from the CCFP this year, is that there was a really big awareness and push of Indigenous health. And, they did courses on it. And I'm just thinking, if we had, like, there's medical evidence for this, and if we did a pilot project and had numbers, which doctors as scientists like, it could even be like offered as a CME at those conferences to sort of, for the next step, attracting more physicians, the like-minded who have a passion for it. Because at the end of those lectures, they would say, arts care, and these are additional resources. So I just sort of, sorry, I just had to say that.
No, so you what Sudi said when you were raised, basically what you're
I had to pray.
Is building up, but you gave a different perspective. He talked about the curriculum and you talked about engaging with physicians through CME. So there's an academic arm of this conversation that we need to build up on. Well said. Okay, colleagues, thank you so much.
We'll be following up. Thank you so much.
Thanks, everybody.
Good to see you all.
Thank you so much.
Stay safe.
Thank you so much.
Thanks so much.
Brilliant, Colin. Thank you.